Just like the skin, the human eye contains melanocytes. These specialized cells are filled with melanin, the pigment responsible for giving the eye its unique color. Occasionally, these melanocytes cluster together to form a benign growth called a choroidal nevus. It is effectively a freckle located inside the eye. This clinical image shows a nevus at the posterior pole, highlighted within the green square, the typical location. Clinicians look for a slate gray or greenish hue. These spots are physically thin, usually under 1 millimeter in height and 5 millimeters in width. Found in 1 to 2% of the population, these lesions are common and typically harmless. However, these same cells can also form choroidal melanoma, the most common primary intraocular tumor found in adults. While 2/3 of these tumors develop from isolated cells, the remaining third mutate directly from those common, stable eye freckles. Because these tumors are highly vascularized, they can spread through the bloodstream, frequently targeting the liver. For the epithelioid cell type, the 5-year mortality rate is 55%. At their earliest stages, a harmless freckle and a lethal tumor look remarkably similar. Accurately distinguishing between the two is the primary goal of clinical monitoring. While a larger lesion increases the probability of cancer, clinicians rely on an 8-step diagnostic framework to categorize the risk and guide treatment. To apply this framework, we have to examine the structural layers of the retina and choroid. The mnemonic used is TFSOM-UHH. T stands for thickness. A lesion exceeding 2 millimeters on an ultrasound is a primary indicator of concern. F represents fluid. An OCT scan may reveal subretinal fluid leaking from the tumor and physically forcing the retinal layers upward. S covers patient symptoms. This includes a drop in visual acuity, flashes of light, or metamorphopsia, a distortion where straight lines appear wavy. O is for orange pigment. On an autofluorescent scan, the presence of lipofuscin creates distinct orange clusters over the mass. These signs indicate the mass is no longer passive. It is an active growth mechanically altering the anatomy of the eye. M refers to the margin. If a tumor is located within 3 millimeters of the optic disc, the risk level increases. A stands for ultrasound hollow. Sound waves passing through the mass reveal an acoustic emptiness at its core. Finally, H and D represent the absence of a halo and the absence of drusen. Because these markers are typically associated with stable, benign lesions, their absence points toward a more aggressive growth. Statistically, the presence of a single factor warrants monitoring, but each additional factor found multiplies the probability of malignancy by 3. A lesion presenting 3 or more of these factors is highly likely to be a malignant melanoma. The TFSOM-UHD mnemonic functions as a risk stratification tool, allowing clinicians to identify lethal tumors while they are still small enough to be treated. A benign diagnosis leads to a simple observation protocol, beginning with a 6-month review and moving toward checkups every 1 to 2 years. A suspected melanoma requires an immediate referral to an oncologist, followed by systemic imaging and liver function tests to check for the spread of the disease. Clinicians may perform a biopsy to identify the cell type, spindle or epithelioid, which determines long-term prognosis. A standard comprehensive eye exam provides a direct and clear window into the health of these internal structures. By identifying cellular changes early, doctors can intervene before a routine finding becomes a life-threatening condition.